Romosozumab and Abaloparatide, a plethora of papers and book chapters. Very importantly, a member and a key contributor to multiple ASBMR and NOF task forces, an NIH grant reviewer, and a review editor for Osteoporosis International for the last 15 years, and the co-editor-in-chief of OI since 2016. That's all I could do with a single breath, but welcome, Professor Cosman, and it's over to you.
Well, thank you so much for that introduction, and thank you for the opportunity to present this lecture today. And I'll echo our colleagues in expressing my sympathies for the incredible COVID crisis, and hope that it gets under control very quickly. So what I will do today is to just kind of provide an update, an overview and an update on anabolic therapy for osteoporosis. And these are my financial disclosures. So specifically, I'm going to talk a tiny bit about risk stratification and identification of the very high-risk patient. Then review the data that support the rationale for an anabolic treatment first strategy for the very high-risk patients, focusing on first fracture risk reduction speed, the ability to sustain fracture risk reductions during antiresorptive therapy after anabolic, and the importance of treatment sequence on BMD gain. And I'll talk a little bit about strategies for patients who are already on antiresorptive agents who remain at very high risk for fracture. So here's a risk stratification schema. I adapted a bit from several of the 2020 guidelines that were published. So low-risk patient fracture probabilities, and in general, these patients don't need any pharmacologic intervention. The moderate risk group can be defined by no prior fracture, BMD levels in the low bone mass range, and FRAX probabilities that are below the usual treatment guidelines, though obviously these differ across different regions. Many of these women don't need medicine, but some, especially in patients who have BMD levels close to osteoporosis range, might benefit from therapy to maintain BMD as the major treatment goal. And these agents might change over time with estrogens early after menopause, raloxifene in the 50s and 60s, and later in the mid and late 60s and beyond, a short course of bisphosphonates. The high-risk patients are women who've had a single prior fracture, BMD levels in osteoporosis range, or BMD levels in low bone mass range with other factors that affect their FRAX probabilities or other absolute fracture risk calculators, producing a 20% major fracture probability or 3% hip fracture probability over the ensuing 10 years. And here, the treatment goals are to reduce fracture risk and to improve BMD levels to above osteoporosis range. And I think age is still a key determinant of the most appropriate treatment for patients in this category, and particularly if the definition of high risk is based on spine BMD, treatment might be different compared with osteoporosis as defined by hip BMD. And for some patients in this high risk category, due to a prior fracture, anabolic agents might be appropriate, but most of these individuals are appropriately treated with either bisphosphonates or denosumab. So now, what about the very high risk category? And the main way that we have defined this, the most consistent way across different associations, is by looking at imminent risk. And that imminent risk of about 10% or more over the ensuing 2 years is the way it has mostly been defined. And it's fairly easy to identify these individuals. These data are from a large population-based study in Iceland, and the dashed line represents the risk of a first major osteoporotic fracture for a 75-year-old woman over a 10-year period. And in the solid line is the absolute risk for a recurrent major fracture, shown as time from the first event. And you can clearly see that the fracture rates are dramatically higher for 2 years after the first fracture, though the risk remains somewhat higher in these patients compared to the woman with no prior fracture throughout the entire follow-up period. These data come from a US Medicare database, very large, over 377,000 women, 65 and older, all of whom had a recent clinical fracture. And the risk of recurrent fracture averaged for all the initial skeletal sites was 10% in the very next year and 18% over the next 2 years after the first fracture. During the remainder of the follow-up period, years 3 through 5, the annualized risk was lower, about 4% yearly. There was also some site specificity to the magnified imminent risk period, where clinical vertebral fractures were associated with the greatest subsequent risk, and that was about 14% having another fracture in the very next year. But even ankle fractures at the bottom of the graph were associated with a 5% risk over the next year and a 10% risk over the next 2 years. So even ankle fractures would meet the high imminent risk criteria of 10% over the ensuing 2 years. And there are similar data from a Swedish study, also a study of over 242,000 women, all of whom had a recent incident fracture. These women were on average a bit younger because the age range went down to 50. And still, the recurrent fracture risk averaged for all initial fracture sites was about 7% over the first year and 12% over the 2 years, only a bit lower than the US database I just reviewed. And again, the specific factors that were found to be associated with the highest imminent risk were clinical vertebral fracture versus other fracture sites, advanced age, underlying comorbidities, and medicines associated with falls. And this is a common theme that we'll see as we review the next few studies. The prior large database studies, of course, can't assess radiographic vertebral fractures because X-rays are not done routinely in these big databases. But we know from a number of studies that the subclinical vertebral fracture diagnosed radiographically is also associated with a magnified imminent risk. And these data are well known to all of you. They're from pooled placebo groups from several clinical trials done many years ago now. And for women with prevalent fracture of unknown timing, the 1-year risk of a new fracture was about 5%. But in women who had a recent vertebral fracture, the subsequent risk of another event was almost 20%, so magnified by fourfold. In addition to recent fractures, we know that patients with multiple fractures are also at high imminent risk. These data are from the GLOW study. This evaluated 2-year fracture rates in women aged 55 and older, and this shows the data based on prior fracture history. So for women with no prior fracture, the 2-year incidence of a first fracture event was 5%. For women with 1 prior fracture, recurrent fracture risk was double that, 9.5%. But for those with 2 prior fractures, recurrent risk was 16%. And for 3 or more, recurrent risk was almost 25%. So clearly, patients who have at least 2 or more fractures, irrespective of timing, are also at very high imminent risk for more fracture events. Prospective studies such as the CAMOS data shown here have evaluated some of the key risk factors for imminent risk, which are not available, obviously, from the large database studies. Here, the focus was on non-vertebral fracture risk over 2 years, which averaged about 5% in this cohort. And the 4 independent risk factors found to be associated with a high imminent risk were recent prior fracture, the patients with recent falls, 1 or more, prior poor physical function, and low total hip BMD, with very high hazard ratios for total hip T-scores below -2.5 and below -3.5. So coming back to this risk stratification schema, we can define the very high risk patient as the woman at high imminent risk based on a recent clinical or radiographic fracture, history of multiple prior fractures, or a total hip T-score in the range of -3 or below, particularly in association with other clinical risk factors such as poor physical function or falling history or a single more remote fracture. And our treatment goals for these women are to improve bone mass and skeletal strength rapidly, to reduce the risk of both vertebral and non-vertebral fractures over a 2-year period of time at which they are at very high risk. So how do anabolic and antiresorptive agents compare with respect to this treatment goal? Here are the data from what is arguably the 2 most potent antiresorptive agents, zoledronic acid in the Horizon trial and Denosumab from the Freedom trial. Of course, we know that vertebral fracture risk reductions are seen within the first year, 60 to 70%. Very robust. But for non-vertebral fractures, we really see little separation between the drug and placebo groups over the first 2 years. And that's what we have defined as the critical time period for the patient at high imminent risk for fracture. Ultimately, of course, we do see risk reductions for non-vertebral fractures, but it takes about 3 years. And the magnitude of that risk reduction is only 20 to 25%. So certainly not as much as we would hope to achieve in these high imminent risk patients. When you look at Teriparatide from the pivotal fracture trial, you see not only a rapid effect against vertebral fracture, particularly prominent for the moderate or severe vertebral fracture, but also a 53% reduction in non-vertebral fractures that occurred in a median treatment period of 19 months. So the effect with Teriparatide is about double the magnitude of the effect that we see with Denosumab or zoledronic acid, and it occurs in about half the time, 19 months, rather than 3 years. When we look at data from the active trial, we see similar efficacy. These are from women who were randomized to Abaloparatide in yellow or Teriparatide in blue compared to placebo, showing risk reductions of 80% for Teriparatide, 86% for Abaloparatide in these modern data for vertebral fracture against placebo. And we also see, when we look at non-vertebral fracture rates, that Abaloparatide reduces the incidence of non-vertebral fracture by 43%, or time to first non-vertebral fracture by 43% over just 18 months. The risk reduction with Teriparatide here in this study was a little bit slower than the risk reduction with Abaloparatide, but was not quite statistically significant. We believe that the difference in efficacy in the active trial for Teriparatide compared to the pivotal trial is related to the underlying severity of the disease in the pivotal trial, less severity in the active trial. Though it's important that even in this broader range of patients with milder disease in some, that Abaloparatide is clearly highly active against non-vertebral fracture in just 1.5 years. We see for the FRAME trial with Romosozumab compared to placebo that for vertebral fracture, there's a rapid risk reduction, already almost statistically significant at 6 months, and obviously highly significant with a reduction of 73% compared to placebo at 12 months. When you look at the non-vertebral fractures from the full frame population on the left here, the difference in non-vertebral fracture risk between the Romosozumab and placebo-treated patients was not quite significant, although very close, the p-value of 0.096. But in the pre-planned subgroup analyses here, we did find a significant interaction between geographic region and treatment effect. And in Latin America, where a large proportion, more than 40% of the population was recruited, and primarily from Colombia, South America, the placebo group non-vertebral fracture incidence was very low, only 1.2%. And you saw no further reduction in this low non-vertebral fracture rate with Romosozumab. But in the rest of the world, which was grouped post hoc, the placebo group non-vertebral fracture incidence was 2.7%, more than twice the placebo group non-vertebral fracture incidence in the Latin American cohort. And in that rest of the world cohort, there was a significant 42% reduced non-vertebral fracture incidence with Romosozumab compared to placebo. When we look at the studies that have compared anabolic and antiresorptive agents in head-to-head trials, such as the VERO trial shown here, we also see the superiority of the anabolic compared to the antiresorptive. Here showing the reduced risk of vertebral fracture at both 12 months and at 24 months in patients assigned to Teriparatide compared to Risedronate in a head-to-head comparison. And for non-vertebral fracture incidence, a clear trend toward reduced non-vertebral fractures seen with Teriparatide compared to Risedronate is seen. The p-value just missed statistical significance since more of the patients assigned to Risedronate had multiple fractures than those assigned to Teriparatide. When you look at the rate ratio for number of non-vert fractures with Teriparatide compared to Risedronate, it was statistically significant, which provides some additional support for the thesis that Teriparatide is superior against all fracture types. In the ARCH study, of course, we compared Alendronate and Romosozumab during the first year and then continued or transitioned to Alendronate in years 2 and 3. And in ARCH, the vertebral fracture risk was reduced by 37% in just 1 year in the group that received Romosozumab compared to Alendronate, and about 50% over 2 years in the group that started with Romosozumab. And at the study endpoint, which was the 3-year endpoint primary analysis, when you look at non-vertebral and hip fractures or all clinical fractures, these are all significantly lower in the group that began with 1 year of Romosozumab and then transitioned to Alendronate compared to the group that was treated with Alendronate alone. So clearly, I think the data show that the 3 anabolic agents all reduce the risk of fracture more rapidly than the antiresorptive therapies. So the next question is, can this be sustained over the next phase, the antiresorptive phase of treatment? Going back now to the active trial, patients after 18 months of treatment with either Abaloparatide or placebo were transitioned to Alendronate for 2 subsequent years. And the Teriparatide group was not continued into the extension trial. But here you can see that the vertebral fracture risk reductions were of similar magnitude during just the antiresorptive phase, as well as the whole cumulative experience through the active and extension trial, the entire 3.5-year study. Similarly, when you look at non-vertebral fracture risk reductions from the extension, the risk reduction was of similar magnitude, about 40% in the group that started with abaloparatide, even after or during 2 full years of alendronate treatment after the 1.5 years of abaloparatide, and no evidence of any convergence of these curves, again suggesting that the bone that's built and the strengthening effect that's built during the anabolic period is maintained and throughout the antiresorptive experience. Similarly, when you look at the FRAME study, this is looking at vertebral fractures now, the magnitude of the vertebral fracture risk reduction is the same over 2 years compared to 1 year. And if you look just at the year 2 data alone, you see an 81% risk reduction for vertebral fracture in the group that started with Romosozumab, even though everybody is on Denosumab during year 2. And when you look at the extension study, clinical fractures and non-vertebral fractures were also, the risk reduction is also maintained over the full 3 years during the extension period in patients who originally received Romosozumab compared to placebo. In ARCH also, when you look at the fracture risk reductions for both vertebral fractures, non-vertebral fractures, and hip fractures, all remain significantly or nearly, or certainly trend level lower in patients who received Romosozumab during year 1, even looking just at the alendronate treatment period during year 2 for vertebral fractures and during the entire open label period for non-vert and hip fractures. So I think it's clear that not only do anabolic agents reduce fractures faster and to a greater extent than antiresorptives, but that the fracture risk reductions are maintained during the antiresorptive phase. So our second treatment goal for these patients is to improve BMD levels to above osteoporosis range. And so what is the evidence to support that treatment goal? And we know that hip BMD on or after therapy with antiresorptives has been shown to predict subsequent fracture risk. That's been shown with alendronate, with zoledronic acid, as well as with Denosumab. We also recently evaluated this in ARCH, and we included all participants in this analysis, both Romosozumab and alendronate treatment. And here we're showing the total hip T-score attained at 12 months, being highly associated with the risk of subsequent non-vertebral fracture. If you look after 1 year of treatment, women who had total hip T-scores which remained below -3, the subsequent risk of non-vertebral fracture was about double the risk in women who attained T-scores above -2. And this relationship was independent of treatment, whether you were on alendronate or Romosozumab. And we saw a similarly strong relationship between total hip T-score achieved at 1 year and subsequent vertebral fracture incidence. When we evaluated spine BMD levels after 1 year of treatment with Romosozumab or alendronate, there was a significant relationship between the BMD achieved and the risk of vertebral fracture, shown here on the right. But in contrast, no relationship between the spine BMD achieved and subsequent non-vertebral fracture risk. So it does appear that hip BMD and total hip BMD looks like the leading site to consider as the treatment target in osteoporosis management. So if hip BMD is so important as a predictor of improved strength and resistance to fracture, how can we maximize hip BMD using anabolic therapy? We know that overall, when you look at hip BMD gain, it is greater when anabolic agents are used first, followed by potent antiresorptives. Here I'm showing data from ARCH. This is showing with 1 year of Romosozumab, followed by Alendronate. You have very large increments in the Romosozumab year in green here, over 13.5% in the spine, over 6% in the hip. And then during the Alendronate treatment period, a continued gain is seen in the first year of Alendronate. Not so much in the second year, is pretty much just a plateau. The 2-year BMD increment associated with the Alendronate phase alone is about 1.5% in the spine, less than 1% in the total hip. When you look at the frame and frame extension BMD data, you see that the 1 year BMD increments with Romosozumab were similar to what we saw in ARCH, as expected. But overall, the 3-year experience provides a greater BMD increment of 18% in the spine and almost or over 9% in the total hip. When you look at just the Denosumab phase 2-year treatment period after Romosozumab, you see an additional 5% BMD gain in the spine, an additional 3.5% BMD gain in the hip, clearly larger than the increments that you see with Alendronate after Romosozumab in the ARCH study. These data were presented at last year's ASBMR, hopefully soon will be submitted for publication. And this looks at the BMD data from both the ARCH and FRAME studies, where we compared the probability of attaining a BMD treatment target, a T-score above -2.5, over 3 years of treatment, with Alendronate alone in red, Romosozumab followed by Alendronate in blue, and Romosozumab followed by Denosumab in yellow. And if you focus first on the total hip on the left, once baseline total hip T-scores are about -2.7 and lower, with Alendronate alone, the probability of attaining the treatment target above a T-score of -2.5 is less than 50%. In contrast, the probability of attaining this target is about 70% when Romosozumab is followed by Alendronate, and almost 90% with Romosozumab followed by Denosumab. And when you look at the spine, when you get to T-scores below -3, again, the probability of attaining a T-score above -2.5 with Alendronate alone is less than 50%. And these probabilities remain high for the two regimens, which begin with Romosozumab, even down to a T-score of -3.5. And we know that when antiresorptives are given first, and then patients are transitioned to anabolic therapy, here looking just at Teriparatide first, that we see differences in BMD gain. For antiresorptive treated women who switch to Teriparatide, hip BMD declines consistently at 6 months. It remains below baseline at 12 months in all of these cohort studies. And for those who transition from bisphosphonates, hip BMD levels finally start to increase above baseline somewhere between 12 and 18 months of therapy. The structure study was designed to determine whether a transition to Romosozumab might be superior to the transition to Teriparatide in women who are switched from bisphosphonate therapy. All of these women had been on bisphosphonates overall for at least 3 years, and specifically Alendronate for the year prior to enrollment in the study, and they were randomized to stop Alendronate and then transition to either Teriparatide in lavender here, or Romosozumab in green. And you can see in the Teriparatide group the well-characterized decline in total hip and femoral neck BMD upon transition. But in contrast, when patients are transitioned to Romosozumab, BMD of both the total hip and femoral neck increased within 6 months, then increased further within 12 months. In the spine, BMD increases with both agents are seen, but even there, the BMD increment is larger with Romosozumab compared to Teriparatide. The treatment sequence for hip BMD is particularly important in patients who start on Denosumab. These are data from the data switch study where the treatment sequences were directly compared in a randomized study. And in women treated with Denosumab for 2 years, followed by a transition to Teriparatide for 2 years, there was a prominent decline in hip BMD, and hip BMD remained below baseline for the entire 2 years of Teriparatide treatment. After 4 years, the hip BMD increase seen with Denosumab first was less than half that seen when Teriparatide was given first, followed by Denosumab. So what about the transition from Denosumab to Romosozumab? And here are results from one of the extensions to the phase 2 dose-ranging Romosozumab study. On the left are women who were treated first with placebo for 2 years, then Denosumab for 1 year, and then Romosozumab for 1 year. And during the Romosozumab treatment, hip BMD remained stable for the year. This effect is certainly better than the Denosumab transition to Teriparatide, but still not ideal in patients at high imminent risk of fracture who need a rapid increase in hip BMD. Another caveat regarding these data are that this is in women who were treated with Denosumab for only 1 year, and we really don't know if the effect of Romosozumab would be maintained to this extent in women who were treated for longer periods of Denosumab before making the transition, and that really needs to be studied. So although BMD effects upon switching from antiresorptives to Romosozumab are better than switching to Teriparatide, treatment sequence with Romosozumab is still important. And here we review the 2 studies where Romosozumab was given first, Arch and Frame, and compare that to the 2 studies where Romosozumab was given after Alendronate from the structure study or after Denosumab from that small phase 2 study extension. On the left are the 1 year hip BMD gains, and you see a mean gain of 6 to 6.2% when Romosozumab was given first. After stopping Alendronate, the gain with Romosozumab was about half that, 2.9%, and after stopping Denosumab, the gain was lower, less than 1%. On the right, when you evaluate the 2 year sequences, we don't have this for the structure study, but hip BMD gain with Romosozumab followed by Denosumab was 8.5%. And in contrast with the inverse sequence, Denosumab followed by Romosozumab, the 2 year gain was less than half of that at only 3.8%. The 2020 ACE guidelines are really consistent with the data I've shown in terms of both defining the very high-risk patients as well as the recommendation to consider treatment with an anabolic first as the best strategy for these very high-risk women. And the IOF algorithm for treatment of very high-risk patients also supports the concept of an anabolic first treatment strategy for better initial fracture risk reduction, greater BMD accrual, and sustained fracture risk reduction during the antiresorptive treatment phase. Obviously, there are always treatment safety considerations that need to be considered. For Teriparatide and Abaloparatide, we're quite sure that osteosarcoma is not a human issue, but it remains obviously in the label which has been changed for Teriparatide, but not yet for Abaloparatide, where it remains a box warning. Hypercalcemia and hypercalciuria, orthostatic hypotension can be seen seen and symptoms associated with that. For Romosozumab, injection site reactions and hypersensitivity, particularly skin hypersensitivity, can be seen. Mild hypocalcemia has been described. But most importantly, the incidence of MACE events, defined as a 3-point MACE here, a myocardial infarction, stroke, and cardiovascular death. There was an imbalance seen, of course, in the ARCH study that was not seen in the FRAME study where Romosozumab was compared to placebo. So in summary, osteoporosis treatment should be individualized and tailored to risk. The very high-risk patients include those at high imminent risk, that is a risk of at least 10% over the next 2 years. And those patients are characterized by having recent fractures, such that the fracture liaison services are really a great way to tap into these patients, but also women who've had multiple fractures, even if not so recent. In addition, people who present with really low T-scores, I think a total hip of -3 or lower, for example, or a spine in the range of -3 to -3.5, especially if there are additional risk factors present, such as a single remote prior fracture or underlying comorbidities or poor physical function, high falling risk. These are all the high imminent risk patients who should be considered for receiving anabolic treatment first when possible to reduce fracture risk rapidly and potently, and to produce the sustained fracture risk reduction during antiresorptive therapy, and to produce the greatest improvement in hip BMD. And for patients who are already on bisphosphonates or denosumab, it does appear that switching to Romosozumab provides a superior benefit than switching to Teriparatide. We don't have this data for Abaloparatide, which might be better in a switch than Teriparatide because it's not as pro-remodeling an agent. But we don't have those data yet. And again, a caveat about switching from denosumab to Romosozumab, where we have very limited data, which is just with 1 year of denosumab treatment. So I'm going to stop there. And again, I thank you for the opportunity to speak today, and to those of you who have participated in this symposium. And I think we probably have a few minutes for questions. Thanks again.
Thank you so much, Professor Cosman. We have a whole bunch of questions, and I realize we're running a little late, but we'll crave your indulgence for a few more minutes. The two categories of questions, one largely dealing with therapeutic threshold, and the other one with therapeutic
the best for the last.
So I will take the liberty of just asking you the two questions on therapeutic thresholds, and then request my co-chair, Dr. Ashu Rastogi, to take on from that. The two questions pertaining to a threshold. The first one is from Dr. Amrish Mittal, who raises the point, the figures of 3% hip fracture risk and 20% risk of major osteoporotic fractures. You know, are they a bit arbitrary, and are they equally applicable across populations, or were they primarily derived from the large bulk of Caucasian data? So that's the first one on that.
Yeah, I mean, very good point. It's totally country specific. It's driven by, to some extent, cost, and I think somewhat arbitrary, but that's a level at which many guidelines are based, and so I use that to try to help define these different categories of risk, but certainly it could be higher based on country-specific prevalence and cost and other factors.
And I had a sort of a similar question. And in one of the earlier slides, you mentioned that the age is an important arbiter in decision making. And while the age at menopause may be relatively similar across populations, lifespan actually varies quite significantly. So you could have some countries which may have a lifespan of 10 or 15 years less than maybe some Northern European, West European populations. Now, will that population-specific FRAC score take into account this potential difference in longevity when coming up with a potential fracture risk, or does that need to be factored in separately while a therapeutic decision is being made? Because the FRAX also has mortality incorporated within it.
Yeah, it's an important question, and I don't think I can answer it fully based on the data that I really try to highlight, which are the 2-year fracture risk, which these data are not derived from FRAX. And in fact, FRAX, it really underestimates the 2-year fracture risk. And there's been, a fair amount of debate about this, and some publications that are about to come out in Osteoporosis International. But I think the key point about these patients who are really at high imminent risk is that we don't need a FRAX tool. We really can go back to looking at patients who've got major, obvious clinical manifestations associated with high imminent risk. That is recent fractures that occurred in the last 2 years, recent clinical fractures, or recently diagnosed vertebral fractures, as well as people with a multiple fracture history. And then extending that to include the patients who present with really low bone mass, where there's a very low probability that they're going to be, cured, meaning that a very low probability that the BMD level will be above osteoporosis range after 3 years of therapy. And those patients are really at very high long-term risk, and most of them will have 10-year probabilities that exceed the treatment thresholds that at least are used in the US. But they also have high imminent risk, particularly when they meet certain criteria, the age, the poor physical function, and so forth. But those are not captured in the FRAX tool for the most part. And so I think the FRAX tool, and really none of the fracture risk tools that I'm familiar with, are so good at identifying these imminent risk people, and we really don't need them to identify them.
Thank you. Can I request Dr. Ashu Rastogi to take over and present the next lot of questions?
Yeah, I would like to take 2 questions regarding therapeutics, and especially by Dr. Sridhar. As bisphosphonates are the most commonly used anti-osteoporotic drugs. So what happens if, suppose, a patient on bisphosphonate fractures? So what should be the ideal go around it? What we should choose now?
So
switches, I think, combinations.
Yeah, I think that, I was a big proponent of the combination approach for those patients because of the data that I showed. When you switch from a bisphosphonate to teriparatide, hip BMD really stays down for, somewhere between 12 and 18 months. So not ideal for the patient who fractures while on a bisphosphonate. And when you add teriparatide to ongoing bisphosphonate, you definitely do better. And we showed this in several papers a number of years ago. But now we have Romosozumab, which has its own intrinsic antiresorptive potential activity. And that kind of duplicates perhaps the idea of combination therapy. You're kind of giving both an anabolic, proforming drug as well as an antiresorptive drug. And the data really show tremendous superiority for Romosozumab in the setting of that direct switch compared to teriparatide in the structure study. And it's not just BMD. I focused on BMD because I think, BMD turns out, DEXA BMD turns out to be so important. But in structure, they also evaluated QCT with volumetric BMD, as well as strength by finite element analysis. And Romosozumab increases strength, volumetric BMD already, pretty dramatically at 6 months, and a further increment is seen at 12 months. That is not seen with the switch to teriparatide. So I think when a patient can take it, a woman who is on a bisphosphonate who fractures should be offered Romosozumab.
Okay. So just to take this question forward, because we expect that a hip BMD would definitely improve with bisphosphonates, but sometimes there is a discrepancy and discordance between the improvement in the hip BMD and what happens at the vertebra. Maybe like major osteoporotic fracture risk still persists in these patients who have now a hip BMD now around 2, but still the vertebral BMD is around 3. So what do you wish to choose now, like shifting to Denosumab or again a combination of Anabolics plus Denosumab?
Well, I think that the hip BMD is a better predictor of what that woman's fracture risk is going to be, particularly for non-vertebral fracture. The spine BMD, when there's a discrepancy, probably the vertebral fracture risk is somewhere in between what's suggested by the hip and the spine. But overall, the woman with the T-score of the -2 in the hip is not as bad off for all fracture risk, as would be suggested by, for example, a T-score of -3 in the total hip. So that's one positive thing. I think if you have such a woman, there's a little bit more open possibility of using Teriparatide or Abaloparatide in that kind of patient, because you're not so worried about the hip. And if even if you lose a small amount, 1 or 2% during treatment with Teriparatide or Abaloparatide, you still will gain spine BMD, and so your treatment, target may be different for this kind of individual. Also, combination therapy would be highly effective for this kind of woman. But of course, switching to Romosozumab would also be, would clearly get her spine BMD to above osteoporosis range and improve her hip BMD as well.
This is a question from Dr. Amrish, sir, and he has inquired about when you choose Teriparatide therapy, do you distinguish between the patient's risk for spine fractures and hip fractures, or it is independent of that?
Yeah, I mean, when I think about hip fractures, I'm usually thinking about all non-vert fractures. So, kind of the more cortical predominant part of the skeleton. And, I did make the point, and I feel very, confident about this, that Teriparatide reduces the risk of non-vertebral fractures, including, I'm sure, hip fractures, though the data, the study, the pivotal trial wasn't large enough to show that. But I'm quite confident about this based on the pivotal trial data showing a 50% reduction in non-vertebral fracture risk. But there was a little bit of a delay with Teriparatide in the pivotal trial. And when you look at the time to, fracture, the Kaplan-Meier curves, there was very little separation before 9 or 10 months. Then the curves start to separate. So I'm very confident the effect ultimately is there, but it may not be as rapid as what we see with Abaloparatide, which is not as pro-remodeling, and it may not be as rapid as what we see with Romosozumab. Of course, we don't have any head-to-head fracture data. Where I think we have more of an issue, though, is after the antiresorptive treatment, that when you stop the antiresorptive, you get an increase in remodeling associated with just stopping the antiresorptive. That's particularly prominent with Denosumab, but you also see it with stopping bisphosphonates, not to the same degree. And then when you add a pro-remodeling drug on top of it, you have further, probably too much resorption, in the cortical skeleton, particularly associated with perhaps some cortical porosity, and certainly no improvement in bone strength in the cortical part of the skeleton during that first, 1 to 2 years. And so that's my bigger concern with teriparatide. But as a standalone first drug, I'm very confident that we see an effect on both vertebral and non-vertebral skeleton.
Back to Dr. Sanjay, sir.
Thank you, Dr. Ashu. If there is no more question, Tandon sir, any more question from your side?
No, I'm fine. I think we are well beyond our proposed session time, and we must respect the timelines given to us.
Thank you very much. Also, thank to all the speakers from overseas, giving their time, all the chairpersons, moderators, to make this event very lively and a lot of interaction. And I would like to specially thank Professor D.S. Rao. So he managed the show. He's a producer of this event. Of course, the executors of the event are Endocrine Society of India, Dr. Ganpati and his team, as well as Department of Endocrinology, PGI Chandigarh, my faculty colleague, Dr. Bansali, Dr. Pinaki, Dr. Rama, Dr. Ashu, Dr. Lisa, Dr. Ramesh played a very, very important role. So I would like to thank all. And of course, the August audience, without that, there is no success of any event. So they contributed significantly and waiting till 10:20 this COVID time. And thank you very much. I'll end my this Thanksgiving here by saying that Sarve bhavantu sukhina, sarve santu niramaya, sarve bhadrani paschyantu ma kaschid bhag bhavet. So that meaning by that everyone should be happy, healthy, and nobody should see the difficulties. So I end my Thanksgiving here. Thank you very much. Thank you. Thank you.
Thanks, Felicia. Thank you so much.
Bye, sir.
Bye-bye.
Bye, Nick.